A very good evening to all esteemed doctors present today evening for this very interesting, extremely scientific webinar. Today's discussion promises a lot of focus on something new, a lot of focus on something renewed, and I promise it's a scientifically packed agenda. My name is Dr. Deepak Bachani. I am from the Ajanta Medical Affairs team. Now, before we proceed with the scientific session, I would like to take a short presentation on Ajanta Pharma. About what exactly is Ajanta Pharma, what is the philosophy of the company, etc. Now, Ajanta Pharma is an Indian multinational pharmaceutical company which believes in the philosophy of serving global healthcare needs through empathy, innovation, and technology. Now, the company has presence in 30 plus countries, 100 plus products, 7,000 plus Ajantites, and 30 plus nationalities. Now, what really sets us apart within the Indian pharmaceutical space is this true differentiated advanced R&D center. Now, this advanced R&D center really is differentiated in the sense of being a huge capacity. It's located in Mumbai. It's a 1 lakh square feet area with 750 plus scientists working for this advanced R&D center. And this ensures the complete value chain from formulation development up till synthetic development, including the very important pivotal steps of analytical development as well as regulatory affairs. Now, we have totally 7 state-of-the-art manufacturing facilities, with 2 of them which are US FDA approved, which can be seen on the slide in Paitan and Dahej. And the remaining 5 have got approval from the other international regulatory agencies. So these are the other 5 manufacturing plants of Ajanta Pharma. Now, the differentiation truly is the innovation, where we have been able to achieve 150 plus first time in India products in the past decade. Now, some of the known drugs within the focused selected segments, which were truly first time in India within cardiology, are shown on the left. The Metexcells, the Synod, and the Atorfit CV. I'm sure a lot of doctors would have heard of Metexcel. Within ophthalmology, we have the prominent App Drops, Olopat, Soft Drops, so on and so forth. Within dermatology, we have Aquasoft, Belanix, and Sunstop. And in the pain gastro segment, we have Feburic, the recently introduced Volstar, and Vertizac. Now, because of working with HCPs, with prominent support, with a lot of guidance, with a lot of association with HCPs from India as well as international, we can boast of various awards and recognition. Notable amongst those include the Time Magazine Young Maker of the Year Award by the hands of the Honorable Prime Minister of India, Narendra Modi ji. Now, as I said, this has been possible because of support and guidance from the HCPs across the globe as well as India. And I would like to take this opportunity to thank all HCPs for this extensive support and inspiration. Some of the other awards and recognitions which we have recently received also include Deloitte Best Managed Companies, the Golden Peacock. The most recent one was the Golden Peacock Business Excellence Award, and so on and so forth. So to sum it up in a nutshell, we strive to be a scientific partner always. That's the end of the corporate presentation. And now I take it forward with the scientific agenda for today. Now, before starting off the scientific deliberation, introductions are a must. Of course, we have stalwarts of gastroenterology present today from India as well as globally. And introduction is not really needed for such stalwarts. However, for the sake of protocol, I will take the next couple of minutes to introduce our extremely esteemed faculty for today. Now, an absolute pleasure and honor to have with us as moderator for today's program is Dr. Parimal Lavate, the Director of the Department of Gastroenterology and Liver Disease at Jahangir Hospital, Pune, a consultant gastroenterologist at Dinanath Mangeshkar Hospital. Dr. Lavate is very well known in gastro circles, a leading gastroenterologist with more than 33 years of experience. Sir is a fellow of various international societies, including the American Gastroenterology Association, a fellow of the Indian Society of Gastroenterology, has participated in extensive research work as well as various workshops under the gastroenterology department, has published various papers. An absolute pleasure to have you. Welcome, sir. On the panel, we have a variety of stalwarts, as I mentioned, from all across India. So pleasure to have with us. Our first panelist is Dr. M. Hariharan. Now, sir is a consultant gastroenterologist, hepatologist, and interventional endoscopist from the Apollo Hospitals, Chennai. Sir has extensive qualification from national as well as international universities, has worked internationally as well as in India, so brings a lot of international exposure. It's an absolute pleasure to have you with us, Dr. Hariharan. Welcome to the program today. Our next panelist is Professor Dr. Subhash Doot. Now, sir is a gastroenterologist from Jaipur and experience of 20 years in this field. He heads the Dr. Subhash Gastro and Liver Care Clinic in Jaipur. He's also associated with Dana Shivam Heart and Super Specialty Hospital. An absolute pleasure to have you with us today, sir, Dr. Subhash Doot. Our next panelist is the very prolific, very prominent Dr. S.P. Desarkar. Now, Dr. Desarkar is a gastroenterologist from the Nightingale Hospital, Kolkata, the immediate past chairman of the National Endoscopy Board of IAGES, the HOD of gastrosurgery at Nightingale Super Specialty Hospital, Kolkata. Apart from that, sir is also the HOD of gastrosurgery, GDDI Hospital, Kolkata. Specialization topics include advanced endoscopy and laparoscopy. A pleasure to have you with us, Dr. Desarkar. Our next panelist is Dr. Manish Kak. Now, Dr. Manish Kak is the HOD gastroenterology at Manipal Hospital, Ghaziabad, an international membership of various international societies, is the editor of the International Journal of Gastroenterology, as well as a reviewer of various other journals like ACG and Case Reports Journal. A pleasure to have you with us, Dr. Manish Kak. I will now request Dr. Parimal Lavate to take it forward to introduce our speaker for today.
So thank you very much, Dr. Deepak, Team Magenta, Aparna, and Manoj Sharma and your entire team for having this very interesting seminar. It is indeed a pleasure and honor to share this platform with none other than Dr. Prakash Gayawali. He is a well-known figure in the field of neurogastroenterology motility, and we have heard his talks n number of times in DDW and so many international forums. He has had a fellowship from the Washington University, St. Louis, MRCP from London, MD from Calicut. So this is our own country, Calicut, Kerala. He is Professor of Medicine, Director of Neurogastroenterology and Motility, Program Director for Gastroenterology Fellowship Training at the Division of Gastroenterology at the famous Washington University School of Medicine. His research and academic interests include esophageal motility, GERD, and functional disorders. He is Director of Gastrointestinal Motility Centers affiliated to Washington University, and is involved in motility testing using high-resolution manometry, esophageal ambulatory pH monitoring and impedance monitoring, wireless pH monitoring, and endoscopic functional endoscopic functional lumen imaging probe. He has had a lot of landmark and pioneering articles in all the top journals in gastroenterology. He is actively involved in clinical research involving neurogastroenterology and motility, and he has over 250 original articles in leading journals all across the board in gastroenterology. And he's the leading reviewer of gastroenterology reviews and book chapters. So we look forward to Dr. Prakash and have a very exciting session. It will be followed by a panel discussion, and then we can have questions from the audience. Over to Prakash.
Thank you. Thank you so much, Dr. Lawate. Thank you, Ajanta Pharma. And it's my honor and privilege to be part of this esteemed panel talking about a very exciting new option or opportunity to manage reflux disease and other acid-peptic disorders. So over the next 30 minutes or so, I will try to take you through why this has been necessary and what the new agent, the new Vonoprazan does in treating acid-peptic disorders. So let's start by first talking about the current standard, which is the proton pump inhibitor. We've had PPIs around for the last 30 plus years, and it's worth trying to understand where exactly these agents stand. So if you think about proton pump inhibitors, established use, one of the primary situations, the clinical scenarios where we use proton pump inhibitors is gastroesophageal reflux disease, all different phenotypes of gastroesophageal reflux disease as listed here. Obviously, peptic ulcer disease and Helicobacter pylori, these are the two areas that we are going to touch on with the new PCAB molecule. But PPIs are also used in a couple of other scenarios, eosinophilic esophagitis, GI bleeding, hypersecretory states, and so on. Over the past several years, there have been quite a bit of press regarding harmful effects of proton pump inhibitors. Now, most of these do not have very strong evidence supporting the harmful effects, but the most common side effects of PPIs are abdominal pain, headache, and diarrhea. And obviously, these create these benign polyps in the stomach called fundus gland polyps. These are completely benign. But on a more persistent or consistent note, there is an increase in gastrointestinal infections with the use of any acid suppressant, including proton pump inhibitors. There's also idiosyncratic microscopic colitis and interstitial nephritis that can happen to some patients. There can be some medication interactions. And once in a while, you will have a patient who just cannot hold on to their magnesium and potassium. They will have a magnesium or potassium losing state that is directly related to PPI. Now, that is infrequent, but those are the more important side effects of proton pump inhibitors. Now, let's focus to start on gastroesophageal reflux disease. And this is the standard management of gastroesophageal reflux disease today. So once we get beyond lifestyle approaches, the rest of the management involves some form of acid manipulation. And when patients don't get better, that's when we start doing tests to confirm or refute the presence of gastroesophageal reflux disease, because symptoms identical to reflux can be created by non-reflux etiologies. And so when patients don't respond, sometimes it's important to confirm that the patient truly has reflux disease. So if you think about the management options of reflux, you're trying to manipulate acid. So you buffer acid with antacids, you inhibit histamine-stimulated acid secretion with H2 receptor antagonists like famotidine or ranitidine, and you disable activated proton pumps that secrete acid with proton pump inhibitors. So the common target here is gastric acid. So if we have all these options for targeting gastric acid, why do we need new options? Well, there are many areas of unmet need within this acid suppression paradigm. Now, the PPIs, the most potent agents so far before the PCABs came into play, PPIs are vulnerable to degradation by gastric acid. So they actually need an enteric coat. And that's part of the reason why we administer prior to meals, so that they get through the gastric component, through the stomach into the small intestine, where the enteric coating dissipates and the PPI gets absorbed. But it does not get absorbed in the stomach. And if you take the pill out of the enteric coated capsule, it actually gets destroyed by gastric acid. PPIs are prodrugs. They get into the small intestine, they get into the bloodstream, and then they must be activated by gastric acid within the parietal cell so that they can covalently bind to the proton pump and disable them. But they only act on actively secreting parietal cells. Only actively secreting parietal cells. So if the patient is given a PPI away from a meal, you're only impacting a very, very small proportion of proton pumps that are actively secreting. Now, meals stimulate the parietal cells, and that's part of the reason why we want the PPIs in the blood circulation when the patient takes their meals and activates 60 to 70% of their proton pumps. They have a very short plasma half-life, 2 to 3 hours. So you have a very narrow window in which to get the medicine into the bloodstream before the meal. And there is also variability in metabolism. They're broken down by this CYP enzyme in the liver. And the patient's metabolizer status of this enzyme can impact how long the medication remains in the circulation. Now, with all these limitations on how the medications need to be taken in relationship to a meal, more than half of the patients who are given PPIs may not be taking it correctly. They may not take it in relationship to a meal. They may take it at bedtime. And obviously, suboptimal PPI dosing translates into suboptimal efficacy of the medication. So what are the frontiers in acid manipulation? One important frontier that I haven't talked about yet is nighttime acid control. So regardless of when you prescribe a PPI, the effects of the acid suppression tail off into the night. And the deep night acid production in the wee hours of the night is usually not suppressed by your daily proton pump inhibitor. So the nighttime acid breakthrough is not controlled by a PPI very effectively. That's why many years ago, people started prescribing H2 receptor antagonists at bedtime to try and suppress this nocturnal acid breakthrough in people who wake up with heartburn in the middle of the night. But that effect, even though you can see that effect, it is subject to tachyphylaxis. So this is a frontier in acid manipulation. Ease of administration, that's what we talked about. Relationship to a meal. Patients forget to take it. It may not be as effective. Better, faster, more complete healing of advanced esophagitis. That's always a target that we need to strive for. And PPIs, from a symptom healing standpoint, as many as half of patients may not have complete relief of their reflux symptoms. And at best, especially advanced grade esophagitis, you get about 70% or so healing of advanced esophagitis. Obviously, better, faster symptom control. It takes up to a week for steady state with PPIs. Then it has to be safe. Why do we say this? Because when PCABs were first developed, there was a serious issue with hepatotoxicity. And that was what led to the PCABs not being advanced when they were first developed in the 1980s, and I will show you that in just a minute. So there's always been concern with any new molecule that there would be this hepatotoxicity issue. And that's part of the reason why it took so long for PCABs to come around. So you'd want the agents to be safe without prominent drug-drug interactions. Now, the potassium competitive acid blockers, the PCABs, in animal studies have enormous efficacy compared to PPIs, so much higher at inhibitory efficacy compared to omeprazole. So what are potassium competitive acid blockers? These are acid-stable agents that do not require enteric coating. They're active drugs. They're not prodrugs like PPI. The molecule that's ingested is already active. They inhibit the proton pump by binding ionically, not covalently, but ionically to both active and inactive proton pumps. So they can bind to a pump, destroy its efficacy, and then release from that pump, and the agent is still available to bind other pumps. There is no need to time dose this medication around meals, and it's not metabolized by that same enzyme system as PPIs, so it's not subject to variability in plasma levels. Here's a brief history of PCAB development. And when we talk about PCABs, we have to talk about PPIs too. So that's when omeprazole was developed. The other PPIs came soon thereafter. The first PCAB was actually developed in 1982, but this did not move forwards, like I said earlier, because of significant hepatotoxicity. And then a second agent, Vonoprazan, was developed in early 2000s, but this was deemed not superior to PPIs. And so it hasn't moved as far forwards. It hasn't gotten as popular throughout the world as you would think. The other PPIs came soon thereafter. And then AstraZeneca tried to develop another PCAB It just had a number. But this agent had efficacy similar to esomeprazole, and there was some concern for hepatotoxicity, so this was abandoned. And then dexlansoprazole came along. But it was 2015 when Vonoprazan was first introduced, and this was safe. This did not have the same hepatotoxicity concerns as the other PCABs. And then others have followed. So this is the timeline for PCAB development. So what do PCABs do? You can see the resting parietal cell on the left and an activated or secreting parietal cell on the right. So the tubular vesicle collapses into the lumen of the parietal cell, and that's where the proton pump resides. So a PCAB, which is already active, goes and attaches to the proton pump and competitively inhibits acid secretion. Now, if you were to compare PCABs and PPIs, in this cartoon, you can see the red pill-like structure, which is the PCAB, attaching to the proton pump, the blue structure on the canalicus lining on the membrane. And that is a bond where the PPI inactivates the proton pump, but the PPI is used up in that process. So it cannot unbind from that proton pump and work on other proton pumps. On the other hand, the PCAB's binding is such that it can inactivate the proton pump and then release itself from that proton pump to work on others. The PPIs also prodrugs, need to be activated, whereas the PCABs, like I said, do not require activation. So to summarize the differences here, PCABs act directly on the proton pump in both resting and stimulated states, whereas PPIs require transformation. The PCABs superconcentrate a lot more than the PPIs do. The PCABs bind competitively and reversibly, that's very important, reversibly to the potassium binding site in the proton pump so that they can release themselves after they have inactivated that pump and work on other pumps. PPIs are used up with the first pump they bind to. Duration of effect is longer with PCABs compared to PPIs. There is no need to administer a PCAB in relationship to a meal, and full effect is achieved with the first dose. There is no time to steady state. So if you were to look at that, look at the effect, you can see at the top, the PCABs have maximal effect with the first dose, with maximal inhibition of acid suppression right away, whereas with a PPI, it takes a few days to get to that point. Now, these are all very nice attributes of the PCAB, but how does it actually function in the management of gastroesophageal reflux disease? We said that one of the frontiers is healing of erosive esophagitis. So this was one of the earlier studies from Asia, a phase 3 multicenter randomized double-blind parallel group study of which about 400 eligible patients. And you can see here that healing of erosive esophagitis at week 8, there was an advantage of Vonoprazan 20 milligrams over lansoprazole 30 milligrams. You may say the difference is not that big here, 3.5 percentage points. But if you look at advanced grade esophagitis, if you look at LA grade C and D, and that's where the problem with the PPI healing is most, you can see that there is a significant advantage of the PCAB over the PPI in healing of advanced grade esophagitis. Now, this is a second study. This is the study that was published in the US, done within the last 2 or 3 years. Another phase 3 multicenter randomized study comparing Vonoprazan 20 with lansoprazole 30, 1,000 patients. Here again, you can see healing at week 8. There was an advantage for all grades, but there was a more significant advantage in healing for LA grades C and D. Again, those advanced grade esophagitis patients healed better. In this study, in that initial healing phase, the advantage over symptom relief was not demonstrated in this first study. So to summarize, Vonoprazan was non-inferior to lansoprazole overall in all patients with esophagitis at 8 weeks, but it was superior to lansoprazole in LA C&D esophagitis, both at 2 weeks and at 8 weeks. So what about maintenance? So there was a maintenance phase for this study, 24 weeks. And here again, there was benefit for vonoprazan, both at the 10 and the 20 milligram dose over lansoprazole in all grades of esophagitis, but particularly so in LA grade C and D, where the gain, the difference between vonoprazan 20 milligrams and lansoprazole 15 milligrams was almost 16 percentage points. So a distinct advantage in advanced grade esophagitis. What about heartburn relief in the other form of gastroesophageal reflux disease, non-erosive reflux disease? This is the more common type of gastroesophageal reflux disease. Erosive esophagitis is only seen about a third of patients with gastroesophageal reflux. This is another randomized double-blind multi-center trial that is just published in the US. Almost 775 patients who were randomized to placebo, vonoprazan 20 milligrams, and vonoprazan 10 milligrams. And the first phase was 4 weeks. At the end of 4 weeks, the patients on placebo were re-randomized to vonoprazan 10 or 20 milligrams, and the patients were followed up for 20 weeks. Here is the 4-week data, and you can see that vertical line where the 4-week time point started. Both vonoprazan doses were significantly better in resulting in symptom relief. So this is percentage of patients with 24-hour heartburn-free days, significantly higher than placebo. Now, there was somewhere between an 8 to 12% gain over placebo with the 10 milligram dose on days 1 and 2, right away. And with 20 milligrams, it was about 20% gain on days 1 and 2. Now, if you looked at percent heartburn-free days, there was again a significant advantage of both vonoprazan doses over placebo in that first 4-week period. Now, if you took out this study and looked at the 20-week data, again, you can see that the patients who were on placebo at the bottom black portion of the front part of this were re-randomized to the 2 doses of vonoprazan, and everybody did well. The mean percent days without heartburn in the final week of the study was around 60%. And the median percent days without heartburn was almost around 80%. So significant benefit, quick, rapid relief of heartburn in non-erosive reflux disease. Here's another Asian study with a similar kind of methodology. Again, non-erosive reflux disease, but this study included low-grade esophagitis. This is a Japanese esophagitis grading. They call it N/M. Excuse me. Sorry, N/M grades. And you can see that in FAS, which is the intention to treat, it just about missed making statistical significance. But in the per protocol analysis, there was an advantage of vonoprazan over placebo here. So in the vonoprazan group, on subgroup analysis, there was earlier relief of heartburn, greater proportions with heartburn relief, and greater proportion with relief at the end of therapy. What about on-demand? So this is something that has been touted as a benefit because the medication acts very early. So from that non-erosive reflux disease study in the US, they selected out patients who were responders. So there were 200 and change patients who had responded to vonoprazan, and then they took them off vonoprazan and asked them to take the medication only on demand, so 10, 20, and 40 milligrams compared to placebo. And you can see that there were more patients with heartburn episodes completely relieved within 3 hours with the vonoprazan doses compared to placebo. And even though they took 3 hours as the endpoint, they also looked at other time frames. And you can see that the relief started at about 1 hour. At half an hour, there wasn't much relief, but at 1 hour, and starting from 1 hour to 1.5 hours, 2 hours, and then 3 hours, there was significantly higher proportions of patients with relief of heartburn compared to placebo. And this is with on-demand use in patients who had symptoms controlled on vonoprazan. So the bottom line was vonoprazan relieves heartburn within 3 hours, and those benefits last about 24 hours. So that was how the study was utilized. Now, what about refractory erosive esophagitis? Erosive esophagitis refractory to PPI. So all the studies that we have talked about so far were patients who were treatment naive for the most part. So this is a systematic review of 12 studies, and you can see vonoprazan 20 milligrams had very high healing at 4 and 8 weeks in these PPI refractory esophagitis. These are patients who had not healed with PPIs. And the maintenance of healing was also in the 80 to 90% range. And you can see symptom improvement always tails healing of esophagitis because there are mechanisms other than reflux, like esophageal hypersensitivity, that drive symptoms. What about complicated patients like scleroderma? So these were situations where a small number of patients with scleroderma with esophagitis that did not heal were switched over to vonoprazan. And there was a significant benefit both in reflux esophagitis and a symptom score using the FSSG questionnaire. And this is a meta-analysis of 19 studies, over 7,000 participants. And vonoprazan was superior to PPI in healing of erosive esophagitis, all grades, starting at week 2. So week 2, week 4, week 8. These are endoscopy-based studies looking at healing of erosive esophagitis. They were non-inferior to PPIs in improvement of GERD symptoms. And I'm not going to talk much about gastric and duodenal ulcers because those are not frontiers in management of acid-peptic disorders, but PCABs were also non-inferior in healing of gastric and duodenal ulcers. Now, again, the meta-analysis also showed that the advanced grade esophagitis, there was a significant benefit over PPIs, more so than in the all esophagitis group. So definitively better in advanced grade esophagitis. So because of all this data, PCABs have made it to GERD guidelines in several parts of Asia. So this is Japan. Mild reflux esophagitis, published in 2022. PCABs have equal status with PPI in the initial treatment of mild reflux esophagitis. And you can see that when they are PPI refractory, the go-to agent is a PCAB, vonoprazan. In severe reflux esophagitis, it is the agent of choice in management of severe reflux esophagitis. In South Korean guidelines, these are South Korean guidelines, you can see at the bottom that in erosive reflux disease, ERD, non-erosive reflux disease, NERD, you can see potassium competitive acid blockers in yellow have equal standing with PPIs. Okay, let's talk for a second about Helicobacter pylori eradication. This is something that may be relevant in India because you have a lot more Helicobacter pylori than we do in the US. So this is a randomized controlled phase 3 trial that was published a couple of years ago, 1,000 patients randomized 1:1:1 to open label vonoprazan, dual, double blind to vonoprazan-based or lansoprazole-based triple therapy. So what are these? Dual therapy was vonoprazan 20 BID with amoxicillin 3 times a day. And triple was vonoprazan or lansoprazole with amoxicillin and clarithromycin. In all comers, the vonoprazan triple therapy was the best. And it in the double-blind phase of the study, it outperformed lansoprazole triple therapy. Dual therapy, not so much. In clarithromycin non-resistant strains, again, vonoprazan triple therapy worked better than the other two. And those are the orange bars here in this figure. And finally, in clarithromycin-resistant strains, the patients who had clarithromycin resistance, both vonoprazan therapy groups, dual and triple, outperformed lansoprazole triple therapy. So dual and triple therapy is superior, with vonoprazan is superior to PPI-based therapy, particularly in clarithromycin-resistant strains. And the experts say that that's partly because the more intense acid suppression allows the acid suppression part to overcome some of the antibiotic resistance. And so you get better results. So that is also true in meta-analysis. So you can see 7 randomized controlled trials and 7 observational studies. In both RCTs and observational studies, Vonoprazan-based therapy outperformed the PPI-based therapies in H. pylori eradication. Quickly talk about safety profile. There is potential for hypergastrinemia every time you suppress acid. And we have information from 30 plus years of PPI use that this is a reversible process and does not lead to a neoplastic or malignant hypergastrinemia. It doesn't lead to a malignant transformation of the EC cells in the stomach, enterochromaffin cells in the stomach. So yes, there is hypergastrinemia, doesn't seem to lead to anything. This is data from the Lauren Lane study published in Gastro last year on safety and tolerability of Vonoprazan compared to lansoprazole. And you can see the side effect profile is similar. And most of the side effects are minor. There were not that many serious side effects, and the proportion of side effects was actually similar to proton pump inhibitors. In systematic review and meta-analysis of all the studies published through 2023, you can see 77 studies. The risk of serious adverse effects and adverse effects leading to drug discontinuation was very, very low. In any category looked at: H. pylori, GERD, peptic ulcer disease, ulcer after ESD, which is endoscopic submucosal dissection. It's used for that indication in Asia. It has not been shown to be superior to PPIs for that indication, by that matter. A few other attributes. The acid suppression is not dependent on CYP2C19 status. PCABs are metabolized by CYP3A4, but they do not induce or suppress this. So there is no real relationship to hepatic metabolism. There's no relationship to interference with metabolism with this agent. There's also no interaction with NSAIDs or agents used in H. pylori eradication. Side effects are minor. Risk of hepatotoxicity is very low. So far, there haven't been any deficiencies of nutrients reported, even though there may be numeric differences. And there is potential for reversible hypergastrinemia, but this does not seem to lead to any negative consequences. I'm going to finish up with 3 vignettes on clinical use of Vonoprazan. These are my patients. First was a 45-year-old gentleman with burning after meals, obese guy. When he came to us, he had not had endoscopy, but he had tried a PPI without benefit. That was his first endoscopy, LA grade D esophagitis. He was put on rubeprazole because rubeprazole has some advantages when other PPIs have not worked. And you can see that his esophagitis downgraded from D to B, but he has not healed. This is refractory advanced grade esophagitis with incomplete healing, persistent symptoms. This is an example of a patient who could benefit from a PPI. I have not scoped him again, but he is on Vonoprazan and his symptoms have improved. At some point, I'm going to scope him again. Here is another example, 67-year-old lady with daily heartburn. She's been on a twice daily PPI for 10 years, frequent dysphagia. And she has been tried on almost every PPI and acid suppressant available. She's a little on the skinny side and has lost weight. She has Crest syndrome. So she has scleroderma, Crest syndrome. And she has absent contractility, and she has a stricture in the distal esophagus. You can see that she has a narrowing, she has esophagitis that is not healed, and you can see that the PPI is actually opened up in the esophagus. The little granules are in the esophagus. So this is a case where the PPI isn't even getting to where we need it to be. So there's unclear timing and absorption of PPI. So this is a complicated GERD patient with a stricture and poor esophageal clearance. This lady was put on a PCAB. I've not scoped her again. She's coming up on my schedule, but her symptoms of especially heartburn have gotten significantly better. And here's one where I do have follow-up. This is a lady with daily heartburn regurgitation for over 10 years in dysphagia. She has an esophageal stricture. She's had 3 separate prior fundoplications, and these have all failed. Most recently, she was on rubeprazole with antacids and alginates. And she had consistent LA grade C esophagitis, even though she has a 3 to 4 centimeter hernia. Because she's had multiple prior fundoplications, the surgeons have said they're not going to operate on her again. And that's been what her endoscopy has looked like for years. And after 8 weeks of Vonoprazan, that's what her endoscopy looks like. So persistent esophagitis, stricture, poor surgical candidates are very good scenarios for PCAB use. So to summarize, this agent is particularly useful in advanced grade esophagitis. Patients who do not heal or have persistent symptoms or are poor candidates for anti-reflux surgery in the context of proven GERD and especially advanced grade esophagitis. They're also particularly good for symptomatic reflux, including on demand. And even though we say on demand can also translate to meaning patients who know they're going to have heartburn with certain foods or certain scenarios. If they take a PCAB before they undertake the trigger event, that is likely to prevent their symptoms for the next 24 hours. Other patient categories, H. pylori eradication, especially in antibiotic resistance, hypersecretory states, and situations where esophageal mucosal healing is paramount, needs to be quick, like Barrett's after ablation or other settings where the mucosa gets denuded in the foregut. There is also some limited study with PCABs in acute bleeding settings, and the new formulations such as the oral dispersible formulation or the liquid formulation could be of value in those patients, but more research is needed. With that, I'm going to finish up. Thank you very much for your attention, and I look forward to the panel discussion. Thank you.
Thank you very much, Dr. Prakash, for this wonderful presentation. I think after listening to your lecture, we are hardly left with any questions for discussion because you have covered the topic so well. But nevertheless, I'll trigger off this discussion by asking a few questions. I'll say the pattern would be that I'll put it to the panelists first, and then maybe you can give your expert comments on that. So first, I'd like to ask Dr. Hariharan that we have a lot of issues about treating H. pylori with the current regimens, clarithromycin resistance, the need for PPIs to be taken before food and all. So do you feel that in our circumstances, Vonoprazan would have a big role in treating H. pylori? Currently, if I'm not really aware if Dr. Prakash knows that we have a lot of these kits available for treatment of for H. pylori in India. But do you feel that we should do them separately? And any comments on dual versus triple therapy, including Vonoprazan? Dr. Hariharan, please.
Thank you, Parimal. Dr. Prakash, that was absolutely wonderful, fabulous lecture. You had covered every bit of what is needed for somebody to know. I'm actually going to quote something from what you've already spoken about, HP eradication. And two things about HP eradication I always keep stressing to people. One is that you really, really need a wonderful acid suppression. See, the key to a good HP eradication is a very good acid suppression and lack of antibiotic resistance. We face these two problems with PPI and antibiotics. We do have a lot of antibiotic resistance in the form of metronidazole and clarithromycin resistance. The only other antibiotic which has shown not to be that resistant is amoxicillin. The resistance to amoxicillin is extremely less. So with the character of Vonoprazan being a significant acid blocker, number one. Number two, it has plugged all the disadvantages of PPI. See, even when we try to give patients, encourage them, tell them that you have to take PPI exactly in the way that they are told to, like before food and other things, many of them, the main reason for failure of PPI is because the way that it is consumed, without any proper advice. So now that you've got a drug where you really don't have to care when you have to take the medicine before or after, and it's quite potent, and it is quite useful. The studies have clearly shown that with amoxicillin, which has shown least resistance, it is quite obvious that the HP eradication rates are going to be good with vonoprazan and amoxicillin combination. Suppose you talk about pre-made packs available, like when we got it with PPIs, but I think we should we should decide what we want to give, because the pre-made packs all come with high doses. The Westerners are able to take, if you take a dual dose, if you take a double vonoprazan with amoxicillin, the actual dose you require is 3 grams of amoxicillin. But I'm not sure Indian patients will be able to tolerate 3 grams of amoxicillin. Although clarithromycin resistance is well known, I think it is not that much as in China. So we can still stick on to the triple drug regime like amoxicillin and clarithromycin, and we should be able to eradicate H. pylori much better. The multiple studies which have clearly shown that in previous PPI antibiotic failures, the vonoprazan combination with antibiotics have been shown to be superior. In fact, the eradication rates really went up from 88 to nearly 95, 98, which shows that the vonoprazan antibiotic combinations are going to be superior. We can have a wonderful eradication with the current regimes. But my only concern is that the 3 grams of amoxicillin would we be able to tolerate? That's the only question.
Ash, any comments on this? In the US, has there been some change in practice in treating H. pylori with the addition of vonoprazan?
Well, it's approved now. The big issue in the US is to get it available to patients. It's easier to get it available to patients for H. pylori eradication than for reflux disease because the duration is short. The drug prescription practice in the US is very dependent on insurance status and insurance covering or not covering the agent. So at cost, vonoprazan is about $600 to $800 a month, which nobody can afford. And so right now, many of the insurance companies have it as a tiered option through a specialty pharmacy. And so availability is improving. And once availability improves, it's going to be used widely. The issue about H. pylori is that it's not that prevalent in the US as it is in India. And so at the tertiary care setting, the patients that we see, these are mostly people who have been through 1 or 2 regimens and have not eradicated. And in those patients, it makes absolute sense to go to vonoprazan. The other thing that it does, I completely agree with Dr. Hariharan. The other thing that it does is it cuts down the number of pills, because our fallback was always the 4-drug regimen. And now, you don't have to go to patients taking multiple types of pills multiple times a day, in addition to not having to worry about when they take it in relationship to meals. So, the compliance is going to be better in addition to proportion healed.
Dr. Manish, we see a lot of patients who have comorbidities, and not so much amongst gastroenterologists, but amongst cardiologists, there's a lot of concern about using PPI and clopidogrel. Although I think there's no great data to support that there can be a worsening of clopidogrel effect. So any comments on using this drug in patients with comorbidities, assuming that both of them are indicated in that particular patient? Because a lot of times when you talk about PPI and clopidogrel, you find that the PPI in the first place is not indicated. But here, suppose we assume that PPI is indicated and the clopidogrel is indicated. What is your opinion on this? Because the metabolic pathway is a little different with the CYP2C19 and CYP3A4 with this. So any comments on this?
I think that CYP2C19 has been there for a long time, mostly in our cardiology colleagues. So whenever we discuss, so this is the point they come up with, that whether we can give PPIs. So the point is that although the metabolism of PPIs and this clopidogrel is through CYP2C19, but sort of it is thought that it inhibits this enzyme, so you have a lower drug levels of clopidogrel in patients who are taking PPIs also. but not too much studies were there that said that actually you should stop, but still this thing is going on. So I think by this vonoprazan, which has a 3A different pathway, so we are bypassing that problem. So a physician would be more confident now in giving the clopidogrel and vonoprazan, because that pathway is bypassed, so there won't be any inhibition of the enzyme. With the result, the interaction will be minimal, and the thought that the drug levels of clopidogrel may decrease or the metabolism may decrease, so this is not in this vonoprazan. So that would be a game changer in this cardiac patients. So that's my take on this.
The situation where we have issues is in people who have renal failure. And again, we'll assume that the PPI is indicated. And it is like, if we look at gastroenterologist and doxycycline, we first think of esophageal ulceration as, although it is not really very common. And we are very wary of using doxycycline. But similarly, we use PPI so frequently, the percentage of people who really develop some renal problems is very low. But if we send our patient to a nephrologist, the first thing he will do is stop the PPI. So, any comments from both you and Dr. Prakash on this issue?
So I would like to begin first, because then Dr. Prakash would correct me. So I think there are two issues with this renal problem. Number one is a person who does not have any renal problem, and he maybe lands up with some issue to maybe ultrasound finding or some other reason. He goes to a nephrologist. So I don't think there's any reason for anybody to stop PPI in a person who does not have any renal problem. Now, the other aspect is that if somebody has a renal problem, say a CKD or any renal failure issues. Now, the problem with PPIs is that why they were telling that, I mean, this thought came that we should not give PPIs in renal patients because it was thought that it causes renal toxicity. Now, the mechanism of this renal toxicity, although is not that very clear, but it is said to cause some tubular interstitial damage, low magnesium levels, changes through gut microbiota. Now, so to my mind, these problems will persist with vonoprazan because changes in gut microbiota, changes in some increase in some bad bacteria in our intestines, some tubular interstitial damage, low magnesium, that is going to remain there with vonoprazan also. That's what I feel. So maybe a person who does not have any renal problem, there should not be any issue, but probably somebody who has a renal failure, maybe we have to be cautious. So I request Dr. Prakash to further enlighten us on this.
So I like your thinking. So the person with no kidney disease, I usually tell the nephrologist, more so than the patient, but the patient too, that fear of side effects should never be a reason not to use an agent, because not many people have side effects. And I tell them, if that was the case, you would not have driven to my office. You'd have taken a donkey or a horse cart, right, to avoid being killed on the highway. So that's the analogy for the patient who does not have a problem and is worried that they'll develop whatever it is, kidney damage, osteoporosis, whatever. They don't have it, don't worry about it. If it develops, we'll worry about it. The person with existing disease, existing kidney disease, it is much, much, much more likely that that's related to diabetes and hypertension and everything else than the PPI. So if they need the PPI, tell them this ain't going to add, this is not going to be the make or break. You'll probably be healthier on the PPI if you have reflux or have risk for peptic disease from aspirin or whatever else they're on. The in-between patient is the one where we need a little bit more discussion. The understanding of the mechanism by which PPIs cause kidney damage is idiosyncratic acute interstitial nephritis. That is the only pathway that has been proven. None of the others have been proven. Those are all speculations. So idiopathic interstitial nephritis. It's like saying, can you get hepatitis, drug-induced liver disease, by taking an antibiotic for H. pylori eradication? Yes, you can. But you take that risk because the benefit is higher than the risk. I think it's the same issue with kidneys. The patient doesn't need the PPI. they don't need it. So we should be looking to decide whether they need it or not. If they have erosive esophagitis, or if they have a history of peptic ulcer disease, or if they're on agents because they have bled before, the benefit outweighs the risk. So would you rather go to the ICU with the GI bleed or worry about kidneys? I think the answer for myself is pretty clear. And that's what I try to tell the nephrologist. I run into the exact same problems that you run into, but that is the argument. Now, if you bring in Vonoprazan, yes, you do have to be careful when somebody has advanced liver and kidney disease. But so far, at least in the patient groups that have been studied, clearly the patients with advanced kidney and liver disease would not be included in these studies. But in the groups that have been studied, there is no de novo development of sinister kidney or liver disease in these patients. Now, the magnesium pathway with PPI is also idiosyncratic, and it has not been reported with Vonoprazan.
Deepak, I hope we have a little more time for discussion. And Dr. Prakash, I hope you have time for carrying on the discussion.
So absolutely, we do have
So
time.
the next question I'd like to ask is for Dr. Subhash. Now, Dr. Prakash has highlighted a lot of side effects related to potential side effects, I would call them as, related to use of Vonoprazan. But it is a more profound acid suppressant. And you have two doses which are available. One is 10 milligrams and one is 20 milligrams. So obviously the 20 milligrams one is likely to cause more profound acid suppression. So would you have any concerns? Because in India, a lot of people are really vegetarians, and then B12 deficiencies can occur and so on and so forth. So any concerns about using these medicines which you have, and any one-liner inputs from the other panelists on this?
Yeah, I am audible.
Yes.
Hello. Yeah. As we know that the absorption of the vitamin B12 vitamin B12 iron require acidic milieu, and prolonged and sustained suppression of the acid may decrease the absorption of these ingredients. So long-term use of PPI in high dose, like the patients in the severe GERD, patient with who has severe acid refractory disorder, elderly patients on the NSAID, they have take the drugs for a very long period of the time. So the prolonged use of the PPI may has some interference in the absorption of the nutrients like B12, calcium, magnesium. And there is also some possibility of that the very long-term use may causes gastric fundal hyperplasia, fundic gland polyps, and a very profound suppression of the acid may increase the chances of the infection in the short bowel like a SIBO. So in the patient who has comorbidity, old elderly age, and in prolonged ICU stay, and we use the high dose of the PPI, or patient in the terminally ill homes use the high dose of the PPI, so may it cause the subacute intestinal bacterial overgrowth in these patients. And because of the absorption in the calcium, vitamin, there is a high chances of the early osteoporosis. But there is no significant till that, no significant scientific data that clearly define that is actually caused by these high dose PPI.
So, Dr. Prakash, would I be right in saying that we have to use practically the same precautions while using PPIs when you are using Vonoprazan as far as these issues are concerned?
Yes, absolutely. The real consequence, which will probably come up in the upcoming years, will be a slightly higher risk of intestinal infection compared to even PPIs because of the profound acid suppression. That's bound to come. That is a biologically plausible mechanism. The nutrient absorption in studies for up to a decade that's available through the Japanese literature, the changes in these nutrients, B12, iron, folate have been just numeric. If the patient started out healthy, there is a numeric decline, but not a deficiency. So, I'm less concerned about nutrient deficiencies, because even if there is a nutrient deficiency there, the mechanism of absorption, the absorption part is not abnormal. So you can overcome that with oral administration if there were to be that issue. But even with PPIs, the people who are deficient already have something else going on. It's very unusual in the average healthy person for a PPI to push them into iron deficiency or B12 deficiency. And I believe, based on the Paul Moeady study, that the calcium homeostasis argument has also been partially debunked, because I try to counsel my patients that postmenopausal state is a much bigger reason for women to be osteoporotic than the fact that they've taken a PPI. Now, the PCAP data only goes a decade, so it'll take a little bit more time to see if that effect is more profound. But the data thus far, the VISION study, which is a big study of data that's available till now, does not report a higher rate of bone fractures or osteoporosis with Vonoprazan for over a decade.
Thank you. Question to Dr. Sarkar now, coming to GERD, because this is a place where it seems to be having a very important place. And in gastroenterology, all of us will believe that it is more difficult to treat a patient with a disorder than one with a disease in many circumstances. So you will have these people with disorders coming to you again and again. And non-erosive reflux disease, in fact, you have to give on-demand treatment. So one question is about, would you feel that you would be using it as on-demand treatment in non-erosive reflux disease, because it acts very fast? By evening, your acid suppression is good and you take one tablet and you should be all right. And the second is in C and D esophagitis, or Savory 3 and 4, if you call it. Would you use Vonoprazan over pantoprazole or the long-acting dexlansoprazole or any such combination? Do you feel you would switch over?
Thanks. First, I must congratulate Dr. Prakash for a very scientific, complete, and lucid presentation, which covers everything. I'm the only person here who does the APC of Barrett's and also the lab fundoplication myself. So the 3 and 4, I think definitely it is, without any doubt, he has proved that the severe esophagitis cases, I'll definitely switch over to Vonoprazan, because that's going to do a lot of things, because here patients also doesn't want to go for the operation, whether lab or others. So those patients, they really want to be on medicine, and definitely Vonoprazan is going to give them a lot of advantage and healing and all these things. Another thing is, in our experience, I've seen that C and D, this severe esophagitis, is much less in India than the Western people. We have A and B type. So types of severe reflux esophagitis, the number are much less. Even the Barrett's changing to the adenocarcinoma, if you compare with the Western literature, our changing of Barrett's to the adeno-C are also very less. So in that scenario, I must feel that Vonoprazan will be a path-breaking thing in this, especially C and D group. And on demand, again, I'm saying these patients, many of them, where the maybe hiatus hernia is there, where the lax things are there. So those are not anatomically corrected unless they go for operation. And Dr. Prakash also mentioned some unfortunate patient who has gone for 3 times fundoplication, still having problem. So I feel that's a very important point, where the on-demand, like when he feels, and he has very nicely explained, the on-demand means when he can predict they're going for a restaurant, going for a festival, going for a ceremony where I may be taking a little different type of foods. So in those cases, on-demand is definitely going to help. I have only one question to Dr. Prakash, that after the left fundoplication, a good percentage people still they have some reflux. What is the role of Vonoprazan in those patients post left fundoplication? Just want to learn that.
So I will answer your question in a couple different ways. One is this on-demand argument. All right, the on-demand argument. How do we reconcile that? And this will apply to that post-fundoplication patient as well. My approach to the on-demand part is to find out from the patient how often they have their symptom. How often they have their symptom, right? If they have their symptom more than 3 days a week, maybe 2 days for some patients, but definitely more than 3 days a week, on-demand is not for them. They need it every day to prevent those episodes. If they have their symptoms once a week, then some form of on-demand may be of value. Some form of on-demand may be of value. And in those patients, the scenario that I presented, where the patient understands what their trigger is, may be the best approach. That will be the most effective way. In that case, they will prevent their symptom rather than having the symptom. Now, the data from the on-demand study suggests that it is only people who have non-erosive reflux disease that responds to daily Vonoprazan that respond to on-demand after you stop the therapy. So you have to keep that in mind. Now, in the lab fundoplication patients who have persistent symptoms, have recurrent symptoms, if their symptom is due to acid, then they will respond. But many of the times, these patients have ongoing symptoms because of esophageal hypersensitivity. That will not respond. That you will need an antacid or alginate or some other traditional means. And again, if they have it very frequently, you may need to put them on a neuromodulator. So I think understanding the mechanism of symptoms really defines how you would use it. Does it work if it is acid? Yes, it does. Do you always need it? Not necessarily. So you'd have to profile the patient a little better. The person who has frequent symptoms that persist all the time, bothersome, every time after meals, wakes up in the middle of the night, that's the particular patient where Vonoprazan would be an advantage over everything else.
Thank you.
So last, actually, one, I would call it a rapid fire question for each of you, including Dr. Prakash, is which indication do you see this agent as a game changer? So
For
Dr.
me, it's
Hariharan, you can start.
Okay.
In one line, which condition you feel this could be a game changer? Anybody else can take it up. I think there's some issue with Dr. Hariharan. So.
I think GERD and more so the refractory one, C and D, would be the game changer. Because these are the ones who have, those who go for strictures, maybe Barrett's, and for so on and so forth. So for me, C and D would be a game changer. However, just before, I would like to ask Dr. Prakash that where does he put Vonoprazan in his practice, vis-a-vis in our practice? So here, the cost is not an issue. And at his practice, the cost is an issue. So where should we put it? Because we get so many queries that should it be the first drug? So a person comes with dyspepsia where the traditional teaching was 4 weeks of regurgitation and symptoms. So it is GERD, so give a PPI and then see and reassess, then go for a refractory and all. So should this be the first drug here, our practice, and what about his practice? Thank you.
So my practice, I like this agent in complicated GERD. So for emptying strictures, some GERD complication, as well as advanced grade esophagitis that doesn't heal. That's the scenario where you're putting the patient at least financial impact in our healthcare setup, because it is going to be more expensive, right? Now, if the cost was equal, and this is something that we talk about all the time, right? If you have a black and white printer and a color printer, which one would you use? If they cost the same, I would use the color printer anytime, right? And the Japanese and Koreans have demonstrated to us that the thought leaders in those countries believe that, right? They place the PCAB at the same level as the PPI in troublesome GERD. Now, does every patient with troublesome GERD need it? We have demonstrated that LA grades A and B don't necessarily have an advantage. So C and D are the ones that have an advantage. But can you tell that just talking to the patient? You can't. So that's the reason why they positioned it early. And clearly, if they are refractory to a PPI, then you jump over right to a PCAB. If cost is equal, if cost is not equivalent, then you'll have to use these tiered systems. Now, at the back end, after you've used it, then you have to again be prudent about weaning down to the least effective dose, or weaning down to the least risky, most effective therapy. And so in some patients, that can be on demand. You can wean it completely off, and you've healed their esophagitis, you've got them off their symptomatic state, and you could go to on demand in that setting. But the advanced grade esophagitis probably need to be maintained at the same dose. And one of the questions was, how does this impact management? I think those advanced grade esophagitis, it will take us away from complicated anti-reflux surgery, because if you can heal their esophagitis, if esophagitis is the need for surgery, is the reason for surgery in somebody without a big hernia, then the PCAB might solve that issue.
Right.
Yeah. Can I make a comment? Sorry.
Yeah, just a very quick comment, because now we are running short of time.
Yeah, I just feel that, in H. pylori eradication, particularly where the people have taken 2 drugs, 3 drugs, and 4 drugs, and still are not been able to clear, where we don't have the facility to culture H. pylori, we feel that, the Vonoprazan will be a game changer. And that's number one. And the other thing, I just want Dr. Prakash to comment. When we talk about PPI, their side effects, most of them are related mainly to intense acid suppression. This is a potent acid suppressant. And so if you take all those so-called, side effects, which may or may not be there, although proven or not proven. So, this has taken 35 years before they started saying that PPIs causes so many side effects. Now the PCABs have come. They are only in US for 2 or 3 years, and we have just started using now. Do you think in another 7 to 8 years, we will get those same sort of papers like we had with PPIs saying that, we know it causes interstitial nephritis, we know it causes hypomagnesemia, we know it causes all other problems very similar to PPIs. Do you think papers will come out saying that PCABs also causes the same sort of side effects?
Yes, they will. And these agents have to be used in patients with comorbidities before those things will come out. Right now, we only have data from people who are well chosen for clinical trials who don't have these comorbidities, right? So most of the PPI side effects are related to the comorbidities rather than the PPI themselves, including the kidney stuff and, people with poor motility, diabetes, hypertension, everything else. Now, once the community starts using these PCABs on a widespread basis and then start publishing their data, or once these statisticians get these insurance claims information and try to cross-reference diagnoses using diagnosis codes, that's about the worst way you can impact healthcare, but that's how people publish these PPI papers. Once that happens, yes, you will see all of these. That's what I predict.
Thank you.
I think I must admire your lecture, Dr. Prakash, because it generated so much discussion. And at this rate, I think we can go on hours on end discussing all these topics and getting your expert inputs. But I think due to want of time, we have to stop here. And over to Dr. Deepak. I think I saw a few of the questions on the chat box, and a lot of them have actually been answered during the discussion. And I guess we can hand over to Dr. Deepak. And my
Yes.
sincere thanks to Dr. Prakash for his excellent lecture, and all the panelists, Dr. Hariharan, Dr. Dev Sarkar, Dr. Dhoot, and Dr. Manish Kak for the inputs. And I'm sure that people who attended this webinar will feel that it was worth their time. And most importantly, it will help them to change their practice in certain areas which were discussed to the benefit of their patients.
Thank you very much, Dr. Lawate. In the interest of time, of course, we will limit the questions to only the ones which were not discussed. So if it is okay with you, we can start off the questions, and we will typically take feedback from Dr. Prakash and one of the Indian experts, if it is appropriate, sir.
I think what we'll do is we'll take just 3 or 4 questions.
Sure. Yes. So
running
we'll limit it to 3 or 4 questions, sir. So there is one question which is talking about, cardiac repeatedly. Is it recommended to use Vonoprazan over PPI in patients receiving clopidogrel, and Vonoprazan is safe or not for cardiac patients. So it's talking about the cardiac angle.
Yeah, I
Yes.
think this question was discussed actually. Dr. Prakash can answer very quickly.
Yes. Yes. To me, the clopidogrel angle has been debunked. You know, this is a issue of lay press not picking up the boring story where it says the medication is safe. They only picked up the story where it said the medication might have a problem. So Paul Moetti has a 10-year follow-up on that original cardiac study, which shows absolutely no difference in cardiac comorbidities with or without PPI in patients who are taking clopidogrel after a coronary intervention. So the clopidogrel PPI relationship is debunked. So if that's the case, then there is nothing with Vonoprazan. If you want to use Vonoprazan, by all means, it's completely safe. The problem is the cardiac guidelines have not followed up on the Paul Moetti study that says that the PPIs are safe. And so the cardiac guidelines from the Cardiac Society still says be concerned and only use pantoprazole, which to me is not based on science.
Sure, sir. So that was a well-rounded, comprehensive answer. So basically, it's no concern, is what I got. So another question. I mean, we'll take just the different ones. So there's one over here. Any likelihood of a combination therapy with the H2 blockers?
No, you don't need an H2 blocker with a PCAB. So the H2 blocker was combined with a PPI because of the nighttime acid breakthrough. PPIs did not suppress nocturnal acid breakthrough, and the H2 receptor antagonist was added at bedtime. It didn't do a good job because it only suppressed nocturnal acid breakthrough for a few weeks at best. PCAB does all of that, so you don't need to combine a PCAB with a H2 receptor antagonist or a PPI. It's a standalone medication that's much more potent than either alone or in combination.
Sure, sir. Another question from Dr. Sanjay Shah. Of course, we discuss about on-demand use. Now here, this is slightly more practical. Many a times, PPIs are prescribed along with NSAIDs just to prevent gastritis. Do you think Vonoprazan can also be used for the same purpose?
There is no study showing that. Nobody has studied PCAB as a preventative agent in the context of NSAID or aspirin use. Now, would it serve that purpose? Yes. Are PPIs bad for that? No. PPIs do a good job. So you'll have to make a judicious decision as to whether you want to go for a more aggressive agent when the existing data suggests that what we use currently does a decent job. And there is no data studying PCABs in preventing gastric erosive lesions.
Sure, sir. So finally, the last question. Now, this is also practical into the sense it's talking about, it's come from Dr. Sanjay Shah. It says which patients require 20 mg and which patients would be appropriate for 10 mg dose.
So the 20 milligram dose is the induction dose that is the dose that is used to induce healing. So for most erosive esophagitis, advanced grade, that period is 8 weeks. So if you're treating somebody with reflux disease and you know the person has advanced grade esophagitis, or you're treating symptomatic reflux and you think the patient has advanced grade esophagitis, but you haven't scoped them, if you want to use 20, it's for the first 2 months, first 8 weeks. The maintenance dose is 10 milligrams. So in my patients who have already been on a PPI, I've not really started them on 20. I've always used 10, and it seems to work just fine for maintenance of healing.
All right. So that was, of course, extremely precise. Thank you very much to Dr. Prakash Gyavali for that excellent session. Of course, it has been said and cannot be said enough. Thank you very much for that very lucid, comprehensive presentation. Thank you very much to Dr. Parimal Lavate for an excellent panel discussion, eliciting great responses, great scientific discussion. I will now pass it on to our cluster head, Mr. Ameya Kumar Pati, to give the formal vote of thanks.
Sure. Thank you very much, Dr. Deepak. Good evening, sirs. As we conclude today's enlightening session, it is my privilege to extend our heartfelt gratitude on behalf of Ajanta Pharma to everyone who contributed to its success, to its grand success rather. First and foremost, We extend our heartfelt gratitude to Professor Dr. Prakash Gyawali, our esteemed speaker today. Sir, your presentation on Vonoprazan, a new paradigm shift in the management of APD, has been both enlightening and inspiring. Your deep knowledge, coupled with your ability to communicate complex ideas in an accessible manner, has significantly enriched our understanding and providing us with new perspective on Vonoprazan in the management of APD. Sir, we truly appreciate your dedication and the time you took out of your busy schedule to share your expertise with us. We also extend sincere thanks and appreciation to our moderator, Dr. Parimal Lawate. Sir, your skillful guidance ensured that our discussion were both engaging and informative. Equally, we would like to express our sincere thanks and appreciation to our esteemed panelists, Dr. Hariharan, Professor Dr. Subhash Dut, Dr. S.P. Des, Sarkar, Dr. Manish Kakot. We are incredibly grateful for your contributions. Your diverse perspective and in-depth discussions have provided us with a comprehensive understanding of the topics covered. Thank you for your dedication and spending your precious time to share your expertise with us. We also thank to our doctor attendees who joined us from various parts of the country, taking the time out from their busy schedule. Your presence, your attention and engagement were crucial in making this event a resounding success, of course. Your questions and interactions added depth to the discussion, making this truly a collaborative and enriching experience altogether. Thanks to Team Ajanta, of course, and our event partners for their relentless support in putting this event together and making it a mega success. Just to inform, sir, we have almost more than 4,200 viewers who has attended and made this event a mega event. Thank you very much and wishing you all a pleasant evening ahead. Thank you, sir. Thank you very much.
Thank you. Our pleasure being here.
Thank you very much.
Thank you. Thank you very much.
Thank you.
Thank you,
Thanks
sir.
a lot,
Thank you.
doctors. Wonderful interaction. 4,300 doctors speaks about the interest level. And of course, the credit goes to the eminent speaker, moderator, all the eminent faculties. Thank you once again, doctor. Thank you.
Thank you, sir.
Thank
Thank you
you.
very
Thank
much.
you. Thank you very
Thank you
much.
and good evening.
Appreciate the opportunity. Thank you so much.
Thank you, sir.